what are the pearls of antibiotic prescription? Can you start like from row number 3? What have you learned about prescribing antibiotics? What are the pearls of prescribing antibiotics? But this is my first and last slide. So happy? So what are the pearls of prescribing antibiotic? If you know those, if you have like got something in your mind by this time, I think so this topic becomes very simple. Huh? We can start from here. Right antibiotic? Right dose. Yeah, very good. Anything else? We really need antibiotics. In some situations, we need to prescribe antibiotics. Correct. Because if you delay, you may add to the mortality. Very good. Anything else? Treat infection, not colonization. Yes. Anything else? Stewardship. This is what we are doing actually. This is what this program is. Antibiotic stewardship. Anything else? De-escalation. Very good. So you people know everything. I think so. It's all covered. De-escalation. So anybody like who said de-escalation? So what do you mean by de-escalation? Speak whatever you know. Huh?
To stop antibiotics at the right time. Usually
stop antibiotics at the right time. So do we have some other meaning of de-escalation? Broad to narrow. Yes, very good. So are we able to do this in a practice? Broad to narrow. So what all things you're dependent on from broad to narrow? Culture reports. So sometimes you may not get the culture reports, or even if you get culture reports, you're not sure what it is. But yes, you should think of broad to narrow. Anything else about de-escalation? Duration of the therapy. Very good. What else? Number of antibiotics. Okay, so broad to narrow, number of antibiotics, 3 to 1. Anything else? IV to oral. This is also de-escalation. So you come from oral IV, come to oral. This is all de-escalation of antibiotics. Anything what you have learned till now? Okay, this is all revision now. Whether we talk about pneumonia, we talk about pancreatitis, we talk about cholangitis. There's nothing much to learn about the antibiotics for a particular infection. The reason being that the microbiology of each infection is different. You should understand what is the flora, what is the oral flora, what is the flora in the community, what is the flora in the gut. And if you know the flora and you know that what are the antibiotics which are susceptible for that particular bugs, you can choose your empirical antibiotic. And as far as the changing of empirical to targeted therapy, you need some microbiological workup, you need some cultures, you need some blood investigations, and then you can just see that this is my antibiotic therapy and I switch over from this to this. Now, this is pneumonia and the focus is on microbiology and pharmacology. So how many types of pneumonia you know about? Just enumerate, anybody? Community acquired pneumonia, yes. Huh? Ventilator associated pneumonia? Hospital acquired pneumonia? Bacterial pneumonia, viral pneumonia, fungal pneumonia, pneumonia immunocompromised, pneumocystis, bronchopneumonia, pneumonia, bronchopneumonia, lobar pneumonia. So we go into the pathological classification also. Anything else? So what is healthcare associated pneumonia? Nobody took the name of healthcare associated. You are right. Now this term has been given up. Why? So what is healthcare associated pneumonia? What is healthcare associated pneumonia? Outside the hospitals and some centers where you're providing some sort of healthcare, maybe like old age homes or some nursing homes, and you're working in some health institution, some person is working in some healthcare institution. So like why the healthcare associated pneumonia has been moved away from ventilator associated and hospital acquired pneumonia. Now we do not talk. Now the healthcare associated pneumonia is not an umbrella for hospital acquired pneumonia or ventilator associated pneumonia. Why? Because previously, like way back in 2005, it was believed that healthcare associated pneumonia, the type of the bugs which you are likely to get is similar to hospital acquired pneumonia and ventilator. But then over a period of time, what the people and the researchers, they realize that any patient who is diagnosed as a case of healthcare associated pneumonia, he first comes to the emergency. So he cannot have that spectrum of bugs which you are suspecting in patients who have got hospital acquired pneumonia or those who have got ventilator associated pneumonia. So those bugs are likely to be different. So healthcare associated pneumonia. So these two pneumonias cannot come under the topic of under the umbrella of healthcare associated pneumonia. So now they are recognized as different entities. So what is the definition of ventilator associated pneumonia? As the name suggests, ventilator associated pneumonia. So the patient needs to be intubated and put on ventilator. So what is ventilator associated pneumonia? Nobody? Okay. What is hospital acquired pneumonia? So patient comes for polycystitis, patient comes from some acute abdomen, patient comes with UTI, patient comes with any other illness without pneumonia. And during the course of the admission in the hospital, he gets pneumonia. That is known as hospital acquired pneumonia. So the hospital has given the pneumonia. And it should be like the patient should not be harboring infection at the time of admission in the lungs. That is hospital acquired pneumonia. And what about ventilator associated pneumonia? Same thing. You've intubated the patient for some other reason. Maybe for low GCS, maybe for neuromuscular weakness, maybe for an acute abdomen and a post-operative case. And what happens is during the course of intubation and ventilation over a period of days, 48 hours, 72 hours, whatever it is given in the textbooks or literature, but then the patient develops a new infiltrate in the lungs. And you go on the rounds and you say, this is a pneumonia. So what is this type of pneumonia? What is this? So what is the name of this type of pneumonia? Huh? Intubated with a tube in situ on ventilator. Ventilator associated pneumonia. Now, a patient who is coming straight away from the community, what are the likely organisms for pneumonia? Anybody? Pneumococcus. Eh? Viral pneumonia. Okay. So we are not focusing on pediatric population. We are not focusing on patients who have got some solid organ transplants or on some immunosuppression or immunosuppressed by virtue of some medical treatment. Any patient who gets hospitalized and then gets a pneumonia and it's considered to be immunosuppressed, that is a separate thing. But we are not focusing on those special group of patients. So any other causes or etiology for community acquired pneumonia? Huh? COVID, yes. Now we have to think of COVID. And even the guidelines suggest, way back, even before the COVID era, 2016, if you look at the IDSA guidelines, ATS guidelines, 2005, when the first time the guidelines came and they were revised, and 2019, they have come with a review of the statement. What they suggest now is 2019, they suggest you must think of flu. If the patient is not responding to your antibiotic therapy in 48 hours to 72 hours, you should do a work of viral infections also. Viral infections. Now and because of the COVID pandemic over the last 2 years, I think everybody would start doing COVID also. Start looking for COVID also. Yeah. Any other organism you feel like? Huh? Klebsiella coming from the community. Maybe, I don't know. Eh? Immunosuppressed, immunocompromised, prior history of antibiotics, receiving dialysis, coming to the hospital, getting dialysis, going back, coming from the community. Klebsiella, correct. You are correct. Alcoholic, I agree. Anything else? Huh? Hemophilus influenza, very good. So see what we are talking about? We are talking about the pneumonia. We are talking about the risk factors. What can be the risk factors for a particular organism? So there are some common organisms which can infect in the community. There are some organisms which can infect that particular patient because of the risk factors present in that particular patient. So guidelines fail there. So what comes into picture? If the guidelines are not working, what is working? Your clinical sense. And you have rightly said, right antibiotic at the right time. So if the right antibiotic is not given at the right time, you add to the You add to the resistance. One. Anything else? You add to the, yes, you add to the mortality. So should we move ahead? Or we should just keep on discussing like this? What is your suggestion? Now this is just an example to show you how a community-acquired pneumonia presents with cough, fever, sore throat. Now this all may even go in favor of COVID now. But you have got like productive cough, no significant past history. On examination, he's febrile, tachycardic, hypotensive, tachypneic, saturation is 91% on room air. Lab is suggestive of leukocytosis, elevated BUN and creatinine. So what is your take? What type of pneumonia it is? What are the different types of like how do you score a pneumonia? Can anybody tell me some scores for pneumonia? The severity of pneumonia. Curve 65. Very good. What else? Smart cough. Very good. Next, BUN. Next, PSIs. Pneumonia severity index. Anything else? And which is the best? Or comparable, or some score has got an edge over the others? Not needed to remember all these scores. Why? Because you need to differentiate which is my sick patient, which patient needs to go to the ward, which patient needs to go to the ICU. And any patient who is likely to get intubated in the next few hours, or the patient is hypertensive at the presentation, is a patient who needs to go to the ICU, nowhere else. That is very clear. So if you keep on doing the scoring, it doesn't matter. But you should know the scores. You have to pass the exams. Okay. And this is how the X-ray may be, a typical X-ray for pneumonia. So is he a candidate for outpatient therapy? No. Why? Hypotension is there. Yeah. And hypoxia. Hypoxia. So what is hypoxia? And what is hypoxemia? Is there any difference, or they are interchangeable? What is hypoxia and what is hypoxemia? Ah, very good. Excellent. Move to the next. What will be your microbiological workup? Emia. Whenever you talk about emia, it is blood. Anemia, hypoxemia, blood, thrombocytopenia, emia. Emia means blood. So hypoxemia means the partial pressure of oxygen in the blood. So when you do talk about PaO2, you talk about hypoxemia. You never say the patient is hypoxic. Hypoxic कैसे बताते हैं? How do you tell? You tell. Okay. So what is the microbiological workup for this patient? Would you like to do a sputum examination of patients who come with community-acquired pneumonia? Yes. Yes. So what type of patients? Where would you like to do a sputum examination? 2015 they had said yes, you could. 2005, yes, you should do. But what are the recent guidelines? Doesn't help. You have to start your empirical antibiotics. Where do you need to do a sputum culture? Where you are suspecting MRSA, where you are suspecting Pseudomonas. So that means the risk factors, they come into play. So if your patient is a high risk for all these other organisms than the normal organisms which the patient is likely to present with, you can do a sputum exam, because then your therapy will become more appropriate. You will not waste time in the other antibiotics, and that patient might be suffering from these organisms. So where you have the risk factors, you think of doing a sputum. Otherwise, if the patient is intubated, what you need to do? ATS aspirate. BAL. So you will do a BAL, or is there any advantage of BAL over ATS aspirate, or it is more or less the same for management? Okay. Okay. But if you want to have some culture for you, then ATS aspirates are as good as BAL. Okay. It is as good. And BAL, like again, logistics. So yes, you can do with ATS plates. Do you need a blood culture for all pneumonias? Huh? Severe community pneumonia, hypotensive, needing ICU admission. Do you need a blood culture? Or ATS plate will do? You need a blood culture. So do you need a blood culture for all community pneumonias? No, they do not add anything. So don't waste the blood of the patient. You need in specific situations only to do a blood culture. Otherwise, it is not needed. Now, what is your antibiotic therapy for this patient? No risk factors, young male, coming with just 2 days history, fever, cough, fever. But yes, he is getting into severe. Beta lactams. Okay. Anything else? Huh? Macrolide. So you want to add or you want to use a single drug? Combination therapy or a single therapy? Combination therapy is preferred over single therapy. Okay, we'll see. Anything else? Any other ideas? Now, this is another case scenario, just as I was discussing. Patient admitted for some acute abdomen, hypotensive shock, underwent surgery, and when we try to wean her off, shifted to ICU post-operatively. When we try to wean her off, we find that we are not able to wean her off. The weaning trial is a failure, and we report that the patient is now having purulent secretions, again tachycardic, again febrile, and you diagnose it as a case of pneumonia. So what type of pneumonia it is? Hospital acquired or ventilator associated? It is a ventilator associated pneumonia. Now after ventilation, this is after ventilation, day 6, 48 hours, more than 48 hours of ventilation. Don't go into those complications of some other vocabulary which has come in 2016. Okay. Now tracheal aspirate is done for this patient and it goes Klebsiella pneumonia, sensitive only to cholesterol. The total duration is she came with an acute abdomen, underwent surgery, 6 days ho gaya. Now you do an ET aspirate and it is Klebsiella which is sensitive to cholesterol. The patient was already on peptides. You want to add? No? Or you want to continue with peptides? नहीं बोलेंगे तो आगे चले. Okay. Okay. So any other workup you need for such patients? Microbiological workup. Besides your ET aspirates, blood cultures for some patients, microscopy, for antibiotics. Do you think of anything else? Huh? TLC, huh? MIC and breakpoint. Okay, so you have a discussion and a dialogue with the microbiologist. I need an MIC, yes, and I need to know the breakpoint. Okay, that is good. So kinetics and dynamics, PKPD. A lecture must have been given to you on PKPD. That is most important to follow. You should understand, and you should not follow what is written in the booklets of the antibiotics. You have to follow the PKPD. What is the role of procalcitonin for antibiotic prescription, especially in pneumonias? Eh? Eh? Yes. So procalcitonin is not to be used for starting your therapy. That is absolutely a clinical judgment. But yes, for de-escalation, it should be used. And even the guidelines suggest procalcitonin along with your clinical judgment should be used for de-escalation. Should be used. So anybody knows about the procalcitonin values? People are used to differentiate viral and bacterial pneumonias based on procalcitonin, but it is not of much use. and it is not to be practiced. Because if my PCT value is less than 0.1, I say it is viral. If it is more than 2.2, I say it's bacterial. But this doesn't have much of sensitivity and specificity. So you can't work on procalcitonin values to differentiate the type of pneumonia. But yes, you can work on PCT for de-escalation of antibiotics. So this should be also a part of this is a part of the microbiological workup. This is a biomarker for infections, and it is very useful for chest infections, pneumonias. So this is what we have already discussed. These are some of the guidelines, the IDSA and ATS guidelines. There are two Indian guidelines also. So one is which came in 2012. This came in lung. And then there is another guideline which has been published by the Indian Society of Critical Care Medicine, 2019. And they talk about all the type of the spectra of infections which might land up the patient in ICU settings. So if you want to go into the depth of these all antibiotic practices, you can just have a glimpse of these guidelines. So this is what the community-acquired pneumonia can be: outpatient, organisms, you should know, because this will decide the antibiotic therapy. Now, if the patient has no risk factors for drug-resistant strep pneumonia, this is DRSP, then you can work with azithro, clarithromycin, or even amoxicillin. And you have a very weak recommendation for doxy, but it also works. We have seen it works a lot, especially in tropical infections. Sometimes it becomes the drug of choice. Comorbidities: patient is immunosuppressed and there is history of antibiotics in the past 3 months. Then a respiratory fluoroquinolone. Now there is again reservations. I'll tell you why about the Indian guidelines are slightly different from these guidelines. And you can use a beta-lactam along with the macrolide. No need to rush. No need to remember the dosage. I tell you, this is not needed at all. It has always to be practiced with the help of the guide. You have to individualize the antibiotic dosage, and that too you may need to do it on a daily basis. Sometimes the antibiotics need to be revised. See, how do you revise your antibiotic dosage on a daily basis or every 48 hours or something? What is your guideline? How do you optimize your antibiotic dosage? Creatinine clearance. So what we are following is creatinine clearance, and based on that we are deciding the antibiotic dosage. Anything else? So basically, what are the roots of metabolism and excretion? Hepatic and renal. So you look at the liver function, you look at the renal function. For renal, you look at the creatinine clearance. What about liver? You look about transaminitis, alphas, cholestasis. Then you decide what is my antibiotics, whether it is reaching the biliary tree or not, whether it is getting accumulated in the biliary tract, it is likely to cause more cholestasis. You choose your antibiotics based on that. So these are some of the practical considerations for choosing the antibiotics at the bedside. Now, if the patient is non-ICU but hospitalized, then there are some species which come up, Legionella, and you have to think of aspiration pneumonia. So how do you diagnose Legionella? Huh? Yeah, good. Yes. So that is one of the, yes, very good. So these are some of the factors which guide you to Legionella. And how do you, what are the diagnostic marker for Legionella? Yes, urinary antigen. So even if the patient gets intubated with Legionella, you can take it even the AT aspirates for Legionella also. But you have to write it that I need it for Legionella. Otherwise, you can do a urinary antigen. Any other bug for which you can do a urinary antigen? Huh? Mycobacteria. Huh? Think. Okay. The patient goes to the ICU. Then some new bugs have added now. Gram negative bacilli. So gram-negative organisms have now come into picture. Like you had that patient who came with an acute abdomen, underwent surgery, and then after 3 days gets intubated and on ventilator for 4 days or 6 days. Grew Klebsiella. So you have to think of gram-negative and you have to think of staph. Now, I told you, like, there are some group of patients who may come straight away with staph pneumonia from the community, but we are restricting to the broader aspect of pneumonia, not talking about specific populations or specific group of patients. And this is the antibiotic. So again, you are restricting yourself to quinolone, you are restricting yourself to macrolide and maybe doxycycline. So these are the 3 antibiotics which are used in this group of patients. For ICU, you may move to beta-lactam with a combination with a quinolone. So this is just a summary. Like, when you treat a patient of community-acquired pneumonia, you should always have a look on the risk factors. So you look at alcoholism history, history of COPD, history of smoking, any history suggestive of aspiration. Is there any lung abscess? If the patient is having like some structural lung disease, bronchiectasis, is he an IV drug abuser? Or he may sometimes see the guidelines do suggest 2 things. Indian setup, you should try to rule out tuberculosis. And in the Western setup, if the history of smoking is there, you should try to rule out lung cancer. So if there is an endobronchial obstruction, always try to do workup for a lung cancer. And then you look for what is the likely path. So this is what the difference is between the Western and the Indian scenario. Now this is just a summary of what the pathogens can be in different patients with risk factors. So Pseudomonas, yes. Pseudomonas is given too much of hype in the Western scenario. For us, Pseudomonas, Acinetto, and they are almost the same. The Pseudomonas, why they talk, all their guidelines talk about Pseudomonas, because this is the bug which is of concern to them. And that is why it comes in the guidelines as a separate entity. And it is difficult to treat. So that is why they have found that Pseudomonas, single antibiotic, combination antibiotic. What are the antibiotics which should be introduced? When should they be introduced for Pseudomonas? So that is why those guidelines always talk about Pseudomonas and MRSA separately, because this is an issue for them. So Pseudomonas, no need to go about the antibiotics, what the dosage are. You should know what is my antibiotic, what can be used, what are Pseudomonas antibiotics useful against Pseudomonas, and you can prescribe depending on the renal and the urine function and the hepatic function. MRSA, vancomycin or linezolid. So what is your take on vancomycin or linezolid for pneumonia? Are they the same or they have got some difference? What else? Yes. Anything else? Yes, very good. Yes. So toxicity is more. Yes. Penetration into the pleural fluid. Penetration into the lung epithelial fluid. So which drug has got better penetration? Linezolid. So that is where linezolid outscores. But then whatever you have told, they are some of the deficiencies which are associated with linezolid. Cost is a huge factor. Because especially, yes, and the volume also. Because initially, whenever the patient lands up with severe pneumonia and you're suspecting MRSA, you will give intravenous, you will not give oral. But yes, linezolid is better as compared to vancomycin. So this is just a summary. Now we move to hospital-acquired pneumonia and VAP. Just look at the global epidemiology, one of the largest data which has been published. And the red ones are from the Asian population. The Sentry registration, 31,000 patients. And you look at the first red, which has got 73 hospitals from Asia. This is just to show that epidemiology keeps on changing. That is why you should always have some inputs coming from the Department of Microbiology every 6 months. and you should have your own antibiotic. So what are the organisms which are going in your particular setting, and what is the sensitivity pattern? Nothing to worry about that. You know the bug, you know what is my sensitivity pattern, and this is your empirical antibiotic choice. You get it from the microbiologist, and it publishes it every 6 months. So you should have that in your ward. Basically, this is what the need is. And if you have any doubts, you can discuss with the microbiologist. So this is extremely important. Antibiogram. Generate your own epidemiological data. And based on that, what happens is, you know what is your empirical antibiotic of choice, and if the patient worsens, you know how to escalate and what are the likely organisms in my particular setup. So that is what, so what the message is. These epidemiological studies may not be applicable to your settings unless and until you do the studies in your own institute. But there are not major differences. If the global epidemiology suggests that now we are taken over by gram-negative infections, so we also have the gram-negative infections. Because whenever these epidemiology studies are published, out of these 73 hospitals, a lot of hospitals were there from Indian subcontinent, Asian countries. So we have this data which is similar to the Western data. And we all know that now the gram-negative infections are more common in the chest as compared to the gram-positive. But MRSA is also growing up very fast in India also. So this is what we have discussed. Antibiograms, unnecessary dual cover is not needed for all patients. Short course of antibiotic therapy. So what do you take on the duration of antibiotic therapy? 5 days, 7 days, 10 days, 2 weeks. Eh? Okay, yes. So if my patient is starting to improve, like you start your antibiotics, and after 48 hours, like the lung infiltrates have come down, oxygen therapy has come down, blood pressure has improved, clinically the patient is improving. So how many days you would like to continue? What is the rationale of 3 days or 5 days? OPD, how many days you prescribe the antibiotics? Okay. So what is the rationale of 3 days? Why do we say that prescribe antibiotic for 3 days or 5 days? And why we are concerned for these 3 days and 5 days, especially in hospitalized patient, it becomes a little different. And if the clinical condition of the patient is not improving, you may go up to 7 days, 10 days. And in some patients, even it is like recommended, you can go up to 14 days. For a particular level in the blood. That would depend upon the dosage and the frequency. So if you have a blood culture positive, what is your duration of antibiotic therapy? Huh? After your negative culture. So that means, so that means you have to keep on repeating when you get a positive culture every 48 hours. I am saying 48 hours, guidelines say something else, but I am saying 48 hours because it is little practical. So Repeat the blood culture every 48 hours. And the day you get a negative culture, from there you count 14 days. So invariably it is more than 14 days. And the reason is what ma'am was telling, deep seated. We do not want any needles left, which can again give a hematogenous spread or again lead to a flare in the infection. So you want to give a complete cover. This is what the rationale is for positive blood cultures. Yes, antibiotic dependent on PKPD, aminoglycoside should not be used as this. You get a lot of sensitivities to aminoglycosides for Pseudomonas, but then it should not be the only antibiotic for Pseudomonas. You need something else along with the aminoglycoside. Then there was a lot of like hype in the last 10 years, combination of rifampicin, combination of this drug along with the other drug. Even if the drug is sensitive to colistin, you want a synergistic, you want an additive action. But then now the guidelines say that if a particular bug, even if it is MDR and it is sensitive to colistin, do not add anything else. Just restrict to a single drug therapy. Now, TG-cycline. Can anybody talk about TG-cycline for pneumonia? There was a black box warning that TG-cycline increases the mortality, and FDA had given a black box warning that do not use TG-cycline for hospital-acquired pneumonia. It is used for community-acquired pneumonia, but not for hospital-acquired or ventilator-associated pneumonia. But then the people did a lot of studies, and even there's a review and a meta-analysis of TG-cycline. You can use it. You can. Penetration is there, yes. So TG-cycline has got a good penetration in the lung tissue. So if you are getting any bug which is sensitive to TG-cycline and you have got a very difficult to treat pneumonia, or the patient has got a risk factors that the pneumonia may not be treated otherwise unless and until you use TG or colistin, you can use TG-cycline, and you can even combine TG-cycline with colistin. So it depends upon what is the clinical situation of the patient. But TG-cycline has got a good penetration in the lung tissue. So you can use it even though the guidelines are not in favor of it. And if you look at the risk factors for MDR, the single biggest risk factor, what is the single biggest risk factor? Prior use of antibiotics. So it is antibiotic abuse. So antibiotic abuse. You have to use antibiotic, but you should not abuse it. If not needed, do not use it. Now this is just antibiotics. I would not like to go into the details, but these are the very well given in the guidelines. You can go through it. Again, with risk factors for MRSA, whatever therapy is going on, you need to think of vanco or linezolid. And if the patient has got a high risk of mortality, then there is a huge list of antibiotics which you can use. But most of the times we resort to carbapenems. And the reason is that you are afraid, you have the fear that the patient may not improve with other therapies. So you need to give a broad spectrum, try to cover whatever organisms are likely to invade that particular patient, so that I start getting an early improvement, and then you try to de-escalate. VAP, yes, it's one of the most common ICO-acquired infection. We are very much worried about VAP. If you go at the rates, it is somewhere 1.2 to 8, but this is not true. If you go into the literature and the epidemiology of VAP in different continents, in different countries, in developing nations or underdeveloped countries, the rate can be as high as 30%. And all said and done, infection control practices. Now, these are one of the most important. You may talk about VAP, you may talk about bloodstream infections and antibiotics, and this is PK, PD, microbiology, culture, stewardship. But ultimately, the one of the most important aspect to prevent any type of infection is your infection control practices. So prevention is better than treatment. You have to always remember that. And Dr. Supriya was telling very nicely, like, it is not just a single, like the doctor has to be just careful. No, each and every staff who is involved in the patient care needs to follow the same practice. And it is sometimes very difficult. So again, the risk factors for MDR and VAP, they are more or less the same. Now, some of the suggestions for empiric treatment of VAP: coverage for staff, if the risk factors are there, cover for Pseudomonas. Suggestions are like, again, the same group of antibiotics. You can use a combination of beta-lactam with BLI. You can use cefepime, levofloxacin, aminoglycosides, combination, carbapenems. So I'm not worried about all these charts and everything. What I think about is the important for you is that you should identify your bug. You should know what the bug is and what are the antibiotics which are sensitive to that particular bug. And then you read the guidelines. Dosage need not be remembered, but you should know that what is the ideal dosage and what is the correct dosage. Now, colistin, how many of you have used or colistin? You have used? So what, IV or inhaled or a combination? Both. See, even if some of the guidelines may go in favor, but like I do not prefer inhaled colistin, and there are a number of reasons for it. I don't mean that I am you need to practice me or that whatever I say is absolute truth. There are some reasons, because maybe my setup is not amenable to use of inhaled colistin. There is some literature, to suggest colistin, because then you are avoiding systemic toxicity, you are avoiding resistance. But the reason is that you do not have the ideal setup to give inhaled colistin. The dosage of inhaled colistin is still not established. You need to have the mesh nebulizers. The dosage is as high as 15,000 million units. How to time them? How to time them when I need to give it to a ventilated patient with my ventilator settings? Do I need to paralyze? How I need to do the secretions before I use the inhaled colistin? Is my nurse understanding that this has to be done before I start the colistin nebulization? So these things, disconnections, adding nebulization. So rather than helping the patient, my paramedical staff may be harming my patient. And when I'm using inhaled colistin, maybe my patient is on high PEEP or high FiO2 also. Maybe he's on moderate to severe ARDS. And those disconnections may be harmful for a patient. So I do not discourage it. If those who are in the habit of using inhaled may use it. But there are some many reasons which, like, there are more disadvantages of using inhaled colistin. And then inhaled colistin. Now, what is your worrying point of whenever you use an antibiotic inhaled? What is your primary concern of that antibiotic? Why you want to give an inhaled antibiotic? You want to break it to as small as possible size. So what is that size? So if it is too small, it goes in and it comes out with each breath. If it is too big, it doesn't go to the lower respiratory tract. So am I able to achieve that or not? So what are the different type of nebulizers? So this is another group of discussion, like what type of nebulizers, how to use it, how to time it, what is my dose, when to give. Should I use it in combination or not? Should I use it for tracheitis or not? So what is, like, there are some good clinical practices. Do a bronchoscopy. Do a bronchoscopy. Look at how your trachea looks like. If your lower part of the trachea look inflamed, but the patient does not have any infiltrates in the lung and you're not worried about it, I may use colistin with my type of nebulizers, which are not able to reduce the size of this colistin to less than 3 microns. Because then I want to deposit that colistin in the trachea only. So I might use it if my patient is on tracheostomy tube or an orotracheal tube for many days. And every time when I do a culture or ET aspirate, I'm growing some organism, has got some risk factors, and is likely to get a pneumonia in the next few days. I might use it, but recommendations may not be there. So that means colistin is like very dicey. So the best route is where you are all, you know what is the dose and how to give it, that is IV colistin. And VAT. Now there is another lot of controversy about treating VAT. But again, the guidelines do not recommend to treat VAT. means ventilator associated tracheitis. Just tracheitis, not any new infiltrate in the lungs. The patient doesn't have pneumonia, but yes, has features of increased secretions. You do a bronchoscopy, you see the trachea is inflamed, you label it as tracheitis. But then there is some group of patients where your concern is that this VAT may get converted into VAP. So again, your clinical sense. Now, dual antibiotics for Pseudomonas. Now, what I believe is that this is important, the second point. So again, the second point comes from where? Comes from your more than 10% of the gram-negative isolates are resistant to an agent which might be considered for monotherapy. So that means you need to have your local epidemiology. Only then you can think of using dual antibiotic coverage for Pseudomonas. These are the Indian guidelines. Please go through it. As far as the Indian guidelines are concerned, one of the important recommendation is that fluoroquinolones should be avoided as an empirical treatment. Why? What is the reason behind it? Yes, for tuberculosis. And even the same concern is for linezolid. So in Indian scenario, vancomycin would be better as compared to linezolid because almost everybody is having tuberculosis. And always try to rule out tuberculosis in Indian patients. Difficult to treat pneumonias, always do a diagnostic workup for tuberculosis. Nothing much, not much of a difference in as far as the other. Yes, this is what we see, Acinetobacter. A lot of Acinetobacter. So you should have your own guidelines. Initial combination therapy based on your local epidemiology and antibiograms. De-escalate. Colistin should not be used as a routine empirical antibiotic therapy unless and until you get some cultures. 7-day therapy should be adequate for most of the patients. Aerosolized, still they say if you can use it as an adjuvant therapy with intravenous colistin. Do not treat VAT. Okay.